So we're going to talk today about fibromyalgia and the fact that the science does support why you are in pain. I am Dr. Martin Rutherford. I am a chiropractor. More important to this talk, I am a certified functional medicine practitioner.
Dr. Randall Gates, I'm a chiropractor as well, but I'm also a board certified chiropractic neurologist.
And these are two separate disciplines. A lot of the folks who are coming here now, some through this video, some through other means, are starting to understand that fibromyalgia is a multifactorial problem and that we have to work with multiple systems. Dr. Gates's discipline works primarily with the brain and the nervous system. You will see why that's important. We're going to discuss a lot of the literature on this. We'll try to make it a combination of academic for those of you who are interested in the science purely, and we'll try to bring that into focus for the layperson. The functional medicine aspect of it deals with the rest. It deals with the bad gut. It deals with the immune system. It deals with inflammation. Indeed, the neurology world is now moving towards covering all of that in their discipline, as it must be, because all of these factors are involved with fibromyalgia. How do we get to talk about this? Those of you who haven't seen us, we get to talk about this because, for one, I have fibromyalgia, and so we started out as actually, we started out doing functional neurology for fibromyalgia. Fibromyalgia patients at that time were pretty much thought to be, it was kind of a junk diagnosis. Unfortunately, for some people, some doctors, it still is, but that's diminishing. And at that point in time, little was known, or at least little was accepted. And we started with fibromyalgia patients, and we started with the fact that there were significant stress mechanisms usually involved. Verbal abuse, physical abuse, sexual abuse, sometimes just massive stress issues. I just lost my husband unexpectedly, or people going through a long stress. That was my particular problem. I was going through a long stress for years and years and years. That was kind of intense, and so stress has a big part to do with it, but it's more than stress. We'll discuss that. And in delving into fibromyalgia, the functional medicine world had their thoughts on it. Ultimately, we started to find out that the thyroid was a big player. We'll talk a little bit more about that, I think. Yeah. The gut is a big player, not because it's the gut, but because of what it exports to the rest of your system. And depending on what it's exporting, it's contributing. There are now guidelines put out by the standard research and medical community for fibromyalgia, and they're improving. They're not as comprehensive as they need to be yet, but it's encouraging that they're moving in the right direction. So we started out with fibromyalgia. We found out that we had all of those things involved. We started seeing fibromyalgia patients had peripheral neuropathy about half the time. We then went to that. We saw that a lot of those had balance problems. Dr. Gates's mentor, Dr. Carrick, primarily was involved with dizziness, vertigo, balance, migraines, as is Dr. Gates, and some other things, concussions. And so that started to meld together. We started to see what this brain fog was, what the fibro fog was. I went to restless leg syndrome, and that's kind of how we got here. Okay, we got here by trial and error. We were using as much of the data as we could back in that day. We kind of understood that immune problems were involved. We were doing massive amounts of autoimmune testing, which was basically, I'll be polite and say, unreliable, which wasn't good because that testing was more expensive. I mean, it was like 10 times more expensive than all the testing we do today to figure out what's going on. We also used food allergy tests, which we also found to be unreliable. So we had to go through these growing pains and these trials and error. And our guideline was results. Our guideline was what worked and what didn't work. And so Dr. Gates came on after that. And Dr. Gates started to review, as I just found out the other day, and you realized you had gone through all the functional medicine. I probably shouldn't say that on here. I took a course, and Dr. Gates was looking at all my notes.
I did not. For the record, I did not.
No, he did not. So anyway, but the point being that together we have developed a functional medicine approach as well as a functional neurology approach, because that's what you are looking at as a fibromyalgia patient. That's what got me to where today I feel like a normal person. I'm articulating well. There was a time when I couldn't speak this well or this clearly or hold my thoughts. I lost my train of thought frequently and blah, blah, blah. I had the pain, I had the peripheral neuropathy, I had the gut problem, I had the thyroid, and then some. So that's how we got here. We feel pretty confident in the data we're going to share with you. So fibromyalgia is real. It's starting to be acknowledged as such. Those of you who are still questioning yourselves, a lot of people come in here and I do the intake consults, are still questioning yourselves as to whether you're crazy or not. You're not. Okay. And to those of you whose spouses may be working, stop telling them that they need counseling. They don't need counseling. Or doctors need counseling. And I mean, I'm just saying, there's a lot of data out there now. If you don't know what the fibromyalgia is and you got a patient and they got every seemingly symptom in the book, at least don't tell your patient they need counseling. Tell them, I don't know what's wrong, and maybe you need to go see somebody who does. So we'll get a little bit more specific into the symptoms, but that's how we got here. A lot of people ask that. You know, we had a patient not just a week ago. Well, how do you know this when the Mayo Clinic doesn't know it? We see a lot of people who've been to the Mayo Clinic. So I've heard that question a lot. That's how we know it. We've done it through trial and error. The medical model is not particularly the best model for chronic pain, as many of you have found out. We may or may not touch on that. We have done hundreds of hours on this. We have other presentations on fibromyalgia. The reason that Dr. Gates chose this one today is so that we can make the definitive point that the science is with you, and it's becoming more and more with you all the time. So let's go through that science. And I'm sure that there are numerous references that are attached to this. When we're done, Dr. Gates goes to great care so that you can look up and read the summations on these research articles yourself, to see for yourself that as we talk here every week, we're not just here spouting theories. Everything we talk about is either we have seen be successful in our treatment, and we have consistently successful results with fibromyalgia to varying degrees, but successful to the degree that you can work with that patient's physiology and stress mechanisms, and that it's also in the science that what we're saying is correct to this date. And it is an evolving situation. But frankly, all the science is doing relative to us is really kind of confirming what we've been seeing in practice.
It's really true.
For over a period of time now. So that's very comforting to us. It's lessening the attacks on us. And that's kind of nice to not have to deal with that. So relative to symptoms, what is fibromyalgia? What is a patient I just said, if you're out there and you're a doctor and you're seeing patients come in and it seems like you think that they're crazy because every fiber in their being hurts. Let's dial that in a little bit for these folks.
And there's a spectrum of it too. I mean, there are fibromyalgia patients where they can barely wear clothes, and there are fibromyalgia patients who function pretty normally, and they may just have some severe pain in certain areas of their body that is unexplained. Basically, fibromyalgia consists of pain, a certain degree of tenderness. So my husband gives me a hug and I hurt, or somebody touches me and I wish they didn't because it was painful. It can also be associated with fatigue very commonly. A lot of fibromyalgia patients have sleep complaints. So you just don't sleep well. You can't fall asleep. You can't stay asleep. You feel unrested with your sleep, so on and so forth. There may be associated brain fog. And then there's also frequently irritable bowel syndrome and or headaches. So it's kind of this like you said, multifactorial condition with a confluence of symptoms, so to speak, or many different symptoms that embody this picture of fibromyalgia. And back in 1990, the American College of Rheumatology came out with their guidelines and said, well, if you're tender, if we press on certain points, if you're tender at 11 out of the 18, then you have fibromyalgia. Since then, the criteria have changed such that basically if somebody has pain throughout their whole body, and there's not really another explanation for it, it's widespread, it's severe, and then they have these other symptoms such as brain fog and fatigue and insomnia and IBS and headaches, then you're probably looking at a case of fibromyalgia. That's the 2010 American College of Rheumatology's guidelines.
Who doesn't want to treat fibromyalgia?
That's a good point. Let's go with that. So today's broadcast, and what we're kind of doing with fibromyalgia, we're doing these repeat updates, I don't know, every 4 to 6 months. We're trying to do those because the new information is coming out and we want to make sure you're abreast of the newest of the newest of the newest stuff. And one of our broadcasts that we did back in January was on fibromyalgia, and we discussed an article from a rheumatologist who basically came out and said most rheumatologists should not be treating fibromyalgia patients. And in fact, most rheumatologists don't want to even see you as a fibromyalgia patient in their office because you are a suck on their system, meaning you take a lot of time. They don't really have a lot of good options for you. And this isn't a knock on the rheumatologists. I mean, they're frustrated because the medications are basically showing to be not that effective. They don't really know what's wrong. Basically, exercise is the most highly regarded treatment for fibromyalgia at this point, as simplistic as that seems. And so that leaves a lot of fibromyalgia patients feeling somewhat dejected because they go to the rheumatologist looking for an answer because that is the quote unquote, God in the inflammatory pain world of the musculoskeletal system. And so that's why we feel there's such a huge blind spot in the fibromyalgia diagnostic workup and treatment paradigm. And that is really the impetus for these broadcasts to basically give greater and greater and greater knowledge, not only to fibromyalgia sufferers, but other clinicians. We're actually starting to talk with clinicians across the globe about kind of how we put this together, not that we're egotistical, but really how the functional medicine, the functional neurology community, and then with our experience now, me going into 6 years of experience dealing with fibromyalgia patients, what really seems to matter clinically and what doesn't.
Yeah, and the point is with the rheumatologist saying the medicines just don't work, so you're not our best patient, is because there's a lot of moving parts. We mentioned them in general, thyroid, gut, and all that. So let's go from, and again, when I say that the medical model isn't ideal for this type of a condition, really that's why. The one drug is not going to synchronize all those moving parts. Multifactorial in English means there's a lot of different moving parts. There's a lot of different systems involved. It's not just inflammation. It's not just the stress mechanism. So let's get into a little bit more specifically how fibromyalgia went from, it's in your head and you just need a psychologist and you just need to pull up your bootstraps, to really putting the pieces of this puzzle together for those of you who may be still suffering from this pretty aggravating and pretty scary condition, especially if you are sitting out there thinking, what am I going to do? Is this ever going to get better? Am I just going to keep getting worse? Where am I going to be in the next 3 to 5 years? You're the one we're hoping to at least give a little clarity to. If we can just even get you to relax and know that there's a solution, trust me, just calming your brain down a little bit by doing this will help you to feel a little bit better. So let's talk about it.
Okay.
Let's talk about the
four
big areas of fibromyalgia.
And just know we pretty much have done a broadcast on each one of these 4 main topics. So I'm not going to go into great length. If you want more information, go back to our other broadcasts on fibromyalgia for more nuances relative to these conditions and their associations with fibromyalgia. But the overview is, back when I was doing my training circa 2006, 2007, at that time in the fibromyalgia literature, the pain literature was discussing how there was this central processing of pain that was abnormal to fibromyalgia patients. In English, what that means is that the brain was not shutting off pain signals. We all have pain signals coming into our body. We all have pain nerves that are discharging, but our brain filters out a lot of those pain signals. It dampens the noise.
If that wasn't working, at all, you probably couldn't put your socks on.
Exactly.
Because you'd be so sensitive to just the pain of the socks going onto your feet.
And then they started to realize that's exactly what was going on with fibromyalgia patients. For whatever reason, they were not filtering out those pain signals. And then literature regarding the effects of stress on the pain system, meaning like psychological stress, post-traumatic stress, became apparent, and they showed that stress hormones had an ability to increase pain signals from the extremities or the body, and that could ultimately result in people feeling more pain because the balance was shifted to them having more pain signals coming into their brain. And then it was thought that when that happens, then the brain learns the pain, and then from there you're stuck kind of in this chronic pain syndrome. After that, around this time, Dr. Rutherford and I, back in 2010-ish, we started seeing all these fibromyalgia patients had thyroid problems, meaning they really had immune system irregularities to their thyroid. So their immune system was showing signs that it was killing the thyroid. But interestingly enough, at that time, the normal laboratory value for the immune cell count to the thyroid was very high. It was around 100 or 60. And that,
in other words, you weren't considered to have a problem unless it was the account was over that.
Right. And now the new criteria is 9. So anything over 9 is being shown to be a problem.
So all of you between 9 and 100 that were told you didn't have a thyroid problem, you did.
Right.
And it's going to be even a lot more complex than that. He doesn't have an hour to go into it. We do have a 1-hour presentation.
Yes.
Multiple 1-hour presentations on Hashimoto's that you'll be able to refer to.
Yeah, and that's what this is called, Hashimoto's thyroiditis. And we started seeing this association. All these fibro patients seem to have Hashimoto's. Well, then Journal of Clinical Rheumatology, January of 2014, came out and said exactly that. They said, well, we are seeing the same association where the Hashimoto seems to be associated with a large degree of fibromyalgia patients, and perhaps the immune inflammation to the thyroid. So the immune system killing the thyroid is creating inflammation in the system, and that's part of the reason why fibromyalgia patients have pain, but also these associated symptoms of fatigue and lethargy and things of that nature, brain fog. So that was a big finding.
And to be fair, it took almost 2 years prior to even Dr. Gates getting here. For my mentor, I want to give him a little kudos, Dr. Datis Karazian, who wrote a book called Why Do I Still Have Thyroid Symptoms If My Blood Tests Are Normal? It's like 4 or 5 years old now. You should read it, okay, because it's about you. And it took him 2 years to convince me that I needed to run a test for Hashimoto's thyroiditis, not just on every patient who came here who was potentially a fibromyalgia patient, but every chronic pain patient. Just a little ditty there. Again, we have stuff on that all over our 250 hours or whatever we got online. So, so it's huge. It's very important that you consider that. If you think you have fibromyalgia, you've been diagnosed with it, and you've been told you don't have Hashimoto's, the chance of you having it is about 99.9% based on our observations. In this office, you come in here with those types of pain symptoms, you're Hashimoto's until proven innocent. And that's pretty much a strong statement, but we're pretty confident that it's an accurate one.
And around 2011, 2012, we were seeing a lot of fibromyalgia patients demonstrating signs of something called small fiber peripheral neuropathy. Neuropathy, as it's generally termed, is where the nerves start to die and degenerate down in the feet, most commonly associated with diabetes. And we were seeing this particular type of neuropathy called small fiber neuropathy, where basically there's degeneration of the pain nerves. And so people have really pronounced pain responses in the feet and the legs. And I was seeing neurological signs of this in a lot of our fibromyalgia patients. And then it was June of 2013 when I first saw it come out. It was an early publication. I think it was later published in November in the journal Pain, where they were seeing the same association, where they saw about half of fibromyalgia patients have small fiber neuropathy. Since that time, since 2013, when it was first early published, and now this has been validated at several different pain centers across the world. So now it's a well-accepted entity within the fibromyalgia literature. And their researchers are trying to get this information out to doctors so that they're more aware of it, because this has huge implications for the fibromyalgia patient, because there is actually something wrong with your nervous system out in your body, if you want to think of it that way. Because people used to think, oh, it's pain in the muscle fiber. That's what fibromyalgia means. So there's something wrong with my muscles. Well, we really now know there's not really anything wrong with your muscles, but there is something wrong with your nerves. And so this was a instrumental finding. The last major piece of the puzzle kind of goes back to the first piece of the puzzle, where we were talking about the abnormal brain processing of pain. And that has since been well established in the fibromyalgia literature. We now know that if you stimulate the hand with electricity in a normal subject and then you do the same thing in a fibromyalgia patient, different parts of the brain light up in the fibromyalgia patient versus the normal individual. So it's almost as though the brain has remapped itself. So just know your brain has a map of your body, and that map can change itself in fibromyalgia patients, as well as the connections within the brain to other emotional processing areas. So what may just feel like a touch to the normal person may actually be interpreted as a painful, horrible, kind of emotionally traumatizing experience to the fibromyalgia patient.
Yeah. And by the way, I hate being touched.
I know.
So again, I'm just saying that from a fibromyalgia perspective, it's a funny thing. You kind of do hate being touched, and your brain can learn that pain.
Forgive me.
On top of, on top of that, your brain can actually learn that pain. So, and I'm not the functional neurologist, but if you are losing that ability to filter out the pain, is that combined with the fact that your brain can actually learn that pain?
Yeah, those two are
combined. So, and I'm trying to not make this too complex, but this is what's happening. So you need to understand some of the drugs are attempting to take care of this, but those drugs over a long period of time come with a high price. For some of you, they don't work at all. These drugs are like Lyrica and Cymbalta and Savella and gabapentin and all these types of things. And interestingly enough, another point relative to Dr. Gates talking about the small fiber neuropathy, still to this day, I have yet to have a patient come in here who has small fiber neuropathy along with fibromyalgia who knows it. They just think, understandably, that all the pain is like, I don't know what it is, but it's all the same. And they are two different issues. And if you have that small fiber neuropathy and you're not going to have that directly addressed, which the medical profession attempts to do with those drugs that I just articulated, which have a very limited ability to do that, as most of you have found. If you don't have that peripheral neuropathy changed and taken care of, then you have very little chance of having your fibromyalgia really affected positively long term. And again, that's another.
And go back and watch our small fiber neuropathy.
I was just going to say that's another.
Yeah,
that's another video on our small fiber neuropathy talk, which you can scroll down on the Hangouts on our powerhealthtalk.com network or whatever it is.
Right. And adding insult to injury, they're even showing that even if you don't have small fiber neuropathy, the brunt of fibromyalgia patients, it's upwards of 80%, I think maybe approaching 90, have been shown to have abnormal pain signals coming from their extremities independent of neuropathy. So it's just like your pain nerves discharge abnormally compared to a normal person. And it's thought to be due to the immune system being abnormal.
So let's talk more about some of the specific data that's coming out that supports what we have presented so far. Let's talk about, so when we're talking about these stress mechanisms, by the way, okay, we're not saying that you're a stress person or you can't deal with stress. These are automatic processes in the part of your brain that literally controls you without you thinking. These parts of your brain help digestion. These parts of your brain help your heart to beat right. They help your lungs to expand and contract. They help your arteries to expand and contract, and all these different types. All the automatic processes in your body that are making you able to be alive that you're not thinking about. You're not thinking about, ooh, my food's now in my stomach and now I need to digest it with hydrochloric acid. All that stuff is controlled by a certain part of your brainstem. And that brainstem is what we're referring to when we're talking about the stress mechanism. And when you go through these emotional issues, like verbal or physical or sexual abuse, or you've had a whole lifetime of at least perceiving that you had bad childhood or abusive childhood, or you walk into the room, or your husband or your wife has just gone through a long, terrible illness and passed away, or your husband, you get a phone call and your husband or your wife just got killed in a car accident, and on and on. You can imagine but what I'm talking about are significant emotional stresses that cause that system to go into something called fight, flight, which is a it's a what's the word I'm looking for? There goes my brain.
Automatic response?
No, it's a survival mechanism.
Right.
It's a survival mechanism, and so when a fibromyalgia patient comes in and we say you have a chronic stress mechanism, we're saying that your brain is in that survival mechanism like always. It just doesn't go out of it, and that causes everything to be wound up and overactive. And I'm trying to learn to articulate it in a better way than saying stress, because when we say stress to people, they think that means I'm sure, and some of you are, but I mean, some of the people are sitting in front of me, they're totally calm, everything that, I mean, you could put a bomb off and it doesn't, and maybe that would set them off. But then when we start looking at their neurological findings, all of the findings are there that their system is going 24 hours a day, they can't fall asleep, they wake up, they can't go back to sleep, a lot of things of that nature, heart palpitations and anxiety and all these things. So let's talk about, so I just wanted to set that definition out because we're going to talk about these mechanisms kind of a couple of times probably before we're done. Which leads us to vagal nerve stimulation. I said all that for that, okay.
So vagal nerve stimulation has been used for a while in the treatment of refractory epilepsy. Seizure patients who have been on every different seizure medication, they haven't really
refractory means they got treated and they didn't get better.
Exactly. So they're being treated with a lot of different seizure medications and they didn't work. So the vagal nerve stimulation, in essence, the vagal nerve, vagus nerve is a nerve that goes to our abdomen from basically our brainstem and innervates our stomach, innervates basically the first 2/3 of your intestines and a lot of your organs like your gallbladder. But it also can send sensory signals up to the brain as well, into an area called the nucleus tractus solitarius. You don't need to know that, but it's in the lower brainstem. And basically, from a very simplistic standpoint, the lower brainstem shuts off the upper brainstem, which is behind the eyes. And the upper brainstem is involved in a lot of these stress-based responses. So from a research standpoint, from a neurological standpoint, fear really generates from an area called the amygdala. That's the fear center. I think a lot of people have heard of that. But that amygdala will initiate brain responses that fire to the area right behind the eyes called the midbrain. And the lower part of the brain, the medulla oblongata brainstem, will shut off the midbrain. I always say the medulla oblongata that way because it was in a movie called The Waterboy. Hopefully many of you have watched it.
Which I didn't see.
Okay, it was a funny movie. Needless to say, the bottom brainstem shuts off the top part of the brainstem, and the vagal nerve stimulation basically can excite that lower brainstem to do exactly that, to shut off the upper brainstem. So for all of you fibromyalgia patients out there who like to research, you may be seeing some information now where they're going to start doing clinical trials using vagal nerve stimulation to help fibromyalgia patients basically to shut off these stress-based responses. Now, with everything we're going to talk about here, these are more medical-based treatments, one thing for one condition, one thing for one type of physiologic abnormality, whereas what we've tried to do, and we've talked about in other broadcasts, is kind of brought it all together.
Well, what we had to do.
What we had to do to help
take these
chronic
bits and
pain
pieces
patients
and put them all together
to make sure that we can address these facets that we listed, from the stress to the Hashimoto's to the neuropathy to
so the vagal nerve
brain
stimulation research is going to say we're going to try and do this for fibromyalgia, which will probably help, but it's not close to taking care of the whole picture.
Right.
So that's what he's saying.
Mm-hmm.
Dopamine. Are you onto that yet?
Yeah, so let's go to
Since we're
dopamine.
talking about the brain.
Absolutely. So dopamine responses in the brain of fibromyalgia patients is showing to be different from normal healthy controls. Another very interesting finding. And that probably ties in with the abnormal brain processing of pain that is seen with fibromyalgia patients. We talked about small fiber neuropathy. I just want to, again, iterate that it is now well accepted. It's been documented in so many different research centers across the world that small fiber neuropathy is an accepted, acknowledged entity that results in the pain associated with fibromyalgia.
Okay. And another term for this stress mechanism that I described earlier and Dr. Gates just alluded to, and probably an accurate term, is most of the fibromyalgia patients are in some level of post-traumatic stress syndrome. I'm very careful about even using that term in the consults to try to describe to the patient what's happening to them, because again, some of these terms like fibromyalgia on post-traumatic stress syndrome and stress have already created certain ideas in patients' heads, and they go, well, I wasn't in the war in Iraq, which some of our patients were, or the Gulf War or anything like that. You don't have to be in war to be in post-traumatic stress syndrome. You just have to have gone through any of the things that I described earlier. So there were some studies indicating that.
Exactly. Well, the studies were indicating they took basically people who had traumatic experiences, normal healthy controls versus fibromyalgia patients, and they noticed that the fibromyalgia patients, their PTSD symptoms were amplified relative to the healthy controls who had also been through stressful circumstances. So not only have we seen, and we've talked about in other research articles that, or other broadcasts, that there are research articles showing an abundance of fibromyalgia patients have been through this post-traumatic stress disorder, but the PTSD seems to be worse in fibromyalgia patients.
Yeah, and really what we've covered up until this point is really the gist of fibromyalgia. I mean, this is the overall picture of fibromyalgia. And we're gonna start covering now just a number of different issues that support different aspects of what we just got done sharing with you. We mentioned that fibromyalgia has a lot of moving parts. Some patients more than others. Some patients, as Dr. Gates said, they're very high functioning. Others can't get out of a chair. They're totally disabled. They're going to pain management doctors, multiple times a month, and so on and so forth. And the mild person isn't necessarily going to get to be that bad. They will get worse, but they may not necessarily get that worse. And so it's kind of a moving target for doctors too, because there is this inability, or I don't know, I shouldn't say inability, but they're just not it's just not even considered that there is this spectrum of fibromyalgia, if you will. And it's an important thing to know if you're trying to diagnose it correctly, and if you're trying to treat it, it's like extremely difficult, important to know. So if you watch our other videos, you'll see how complex it can be. If you don't know all of these things, it's like impossible to figure it out, and it's impossible to address. But the medical profession is starting to get an idea that maybe a multimodal approach might be better. So we'll tell you, let's share with them what their multimodal approach is. And when I say there, again, every single time in every video, we've always said we are totally not anti-medicine. It's just that medicine has its strengths are in certain areas, acute problems, acute emergency types of problems, and then way over here, pathology. You've got cancer, you've got a tumor, you've got whatever, a broken leg. We need to do all these life-saving things for you, but you are here in the middle. And this is where medications and the medical model of diagnosis are not optimum. Okay, I mean, it's just a fact. But we do work with medical doctors regularly. We work with functional psychiatrists. We work with hypnotists for the stress mechanisms when you can't just get them down with simple procedures or nutritional approaches or things of that nature. So the medical multimodal approach is beginning to be considered, and it is.
And it basically consists of their way of dealing with these multifactorial issues. It involves sending you to cognitive behavioral therapy to deal with your trauma. It involves giving you amitriptyline, which is an antidepressant pain medication has been shown to be mildly effective for fibromyalgia patients if it's used and then it's taken away and then it's used again. And then also basically to have you exercise or go to physical therapy, because exercise is the one thing that seems to be marginally effective for fibromyalgia patients. So this is their way of addressing a few disparate pieces of the syndrome.
Yeah. So there's a lot more pieces going on in that. We're all for cognitive therapy, certainly in the beginning or during certain cases. But if you have anywhere of like a moderate to severe case, I would say this is kind of like peeing on a forest fire, trying to figure out, trying to affect the types of conditions that person is having. And the chances of long-term success are non-existent, really, because these are not going to get to the bottom of the things that are creating. This is not going to, counseling is great, but it's not going to shut down that stress mechanism. And amitriptyline, maybe it takes the edge off, but it's not affecting the brain function. That's not filtering out the pain. And your super sensitive nerve endings. And the PT is good, but it's primarily going to affect the muscular issues that aren't the primary issues. They're secondary to the nerve issues. And again, this is not a cut. If you're a fibromyalgia patient, I'm talking to you, remember, I've gone through this. Okay, so I'm just trying to give you data so that you can have the data so that you can make educated decisions on your own. Or at the worst, if these things aren't working for you, if these addresses aren't working for you, don't buy the argument that it's you. Okay, it's not you. It's that these are the baby steps of the medical model moving in the direction of understanding it. There are a lot of models, and in the medical world, here's how it's going to work. You're going to go to one person for this, one person for that, one person for this. And eventually when they figure out the 50 things that can be causing it, maybe you'll be going to 50 people, I don't know. But it needed to all be pulled together into one model. And that's what I can't, there may be a couple of other people in the country that are doing this. We're kind of aware of other people that are maybe doing this in the country. Maybe they're a handful, but this is what we had to do, okay, to be able to consistently, successfully address these cases, assess them, and address them. So let's talk about like chronic fatigue syndrome and fibromyalgia. They go one-on-one. If somebody comes in here and they're fatigued, we're going to go thyroid, blood sugar, stress, and gut. Well, with the exception of the blood sugar, sounds pretty familiar to what we just got done saying, huh? So let's talk about that and how they kind of go together, and the research shows it.
So when we see chronic fatigue with fibromyalgia, they're acknowledging that it's more severe than just chronic fatigue by itself. Chronic fatigue syndrome patients, I'll tie it in, they're now trying to label this as a new disorder. It used to be referred to as myalgic encephalomyelitis, which is a bad term. Now they're trying to call it neuroinflammatory and oxidative fatigue disorder, which is basically acknowledging that there's an inflammatory component. There's not really anything wrong from an immune system perspective, like they don't have rheumatoid arthritis, but there are some abnormalities there. We're seeing that the energy processing parts of the cells of our body are abnormally functioning in chronic fatigue. We talked about how cortisol profiles can be off in chronic fatigue. There may be infectious triggers to chronic fatigue. So again, it's another multifactorial illness, but there can be overlap of chronic fatigue with fibromyalgia because everything I just mentioned can tie into the fibro aspect like we've been talking about significantly through here.
Right, and all that can be addressed, by the way.
Yeah.
So for those of you who've been told you need to pull up your bootstraps, our next research article might be encouraging to you in some way. So just so you're not feeling like, my God, maybe they're right. Maybe it's in my head. Maybe it's me. Fibromyalgia is not a personality disorder, people. It's not. Everything that we're talking about is affecting your brain's ability to work. And it's just affecting the brain chemistry in your brain. Your brain in its essence is overfiring in and of itself. Next study kind of at least helps you to understand that's not you. That's not in your head.
Exactly. Which one are you going at? Just so I
modifying ADLs.
Yeah, exactly. That's what I was thinking.
Yeah.
So
I'm setting you up here.
I was just making sure.
Setting you up for victory.
So now they're talking about, well, your activity as a daily living as a fibromyalgia patient, meaning, you get up, you put the laundry in the washer, you're making coffee. They're saying that physicians need to advise fibromyalgia patients to be aware of what they're doing in their daily lives and really tone it back. So you need to acknowledge that when you reach for the mouse to click on the computer screen, that may cause you extra pain. So you just need to move slower. You need to not reach as far. You need to not bend over as much. This is good because at least doctors are going to be advising patients, about their limitations and not overdoing it. By the same token, I feel it's not really getting to the cause of the problem either, which we now know. It's not like we don't understand what's wrong with fibromyalgia. We do at this point.
Right.
So,
and a practical aspect to that is that fibromyalgia patients have a what's called a
poor metabolic capacity.
Poor metabolic capacity. I was going to say threshold, but poor metabolic capacity. And what that means is you have a threshold of activity in which if you exceed that threshold, and you're going to know what I'm talking about right now, you get a good day. Here's another hallmark of this. You'll get better days than others. Some days you might actually feel good. And then you go out into the world, into your daily activities, and do everything you haven't been able to do for the last week, and then boom, you crash. Here in this office, the first day that we have a fibromyalgia patient in there, we usually utilize some modalities, a little bit of what you might talk about here, to see if we can get a change in nerve function in the patient. They're very low key because we understand that fibromyalgia patients are sensitive, that their stress threshold, the brain stress mechanism threshold might be low, that their pain threshold might be low. And even as low a stimulation as we have, sometimes that patient will feel worse. Doesn't mean we're making them worse. It just means that we understand how much is going on, how low their threshold is, and that we just have to work under that threshold. So, so your activities of daily living will crash that threshold. And so it's, again, it's not in your head. They've done studies that show, yes, indeed, what we've been saying for years and years and years and years and years and years, after observing thousands of patients, is correct. That it's not in our head, that it's not your head, that all these situations, all of these conditions come together, and they just lower your ability for your stress mechanisms and your immune function and your biochemistry to handle that extra activity that you put in there on those days where you just have to do something or you're feeling better. The rest are kind of, I don't know, you already talked about this, didn't you? The stress and the cortisol levels. We use stimulations. I guess you'll talk about that.
Yeah, let me talk about those too. We've seen an association with restless leg syndrome and fibromyalgia patients for a really long time. It seemed like every fibromyalgia patient came in with restless leg syndrome. That's now been validated in the literature with musculoskeletal pain. They looked at it in Australian adolescent and early 20s, I think, female patients. And part of the reason is because of the pain, you're going to have abnormal brain processing of that pain, and there's maybe a tendency for a restless leg syndrome-like picture. Also, we feel that the association now of small fiber neuropathy with fibromyalgia, and neuropathy is associated with restless leg syndrome. So there's probably a large degree of overlap there too, such that there's neuropathic RLS that a lot of fibromyalgia patients have been dealing with, but have not been diagnosed with such until recently, because a lot of doctors weren't even aware that fibromyalgia patients had small fiber neuropathy. This next
and one other thing,
sure.
A lot of you fibromyalgia patients have like a chronic low-grade anemia,
right? Yeah.
And one of the things that causes restless leg syndrome is low iron, and the anemia, usually it's in the form of the patient sitting in front of me and saying, "Yeah, I have this anemia my whole life," and nobody knows what it is. Usually, the anemia is secondary to the inflammatory response or the immune response, or both, from the fibromyalgia. So the key, to give you one example of getting to the cause, the key is to calm everything down that's causing your fibromyalgia, and then your iron will come back. But relative to restless leg syndrome, that's restless leg syndrome. One of the things that causes it is low iron, just for the record.
Exactly.
Okay.
So there's a new treatment being termed high definition transcranial direct current stimulation.
Say that 3 times.
Kind of along a similar premise of transcranial magnetic stimulation, which is where they're basically putting magnets or electrical current over the brain in a select area, and basically trying to put either electrical current or magnetic pulses, which are going to affect electric fields in the brain and how your brain fires. And this is kind of the simplistic way to go about it, in terms of saying, okay, so we know there's an element where the brain does not process pain signals well in fibromyalgia patients. We know that there are abnormal neuronal networks involved in fibromyalgia patients, meaning when you touch a fibro patient, not only does their sensory area of their brain light up, but so does the emotional area. So possibly we can affect this by putting these currents or these magnetic fields over the brain. And they're showing that there can be an effect, but again, it just goes back to like how we treat neuropathy. You know, you can put electrical current into the feet of a neuropathy patient, that's all well and good, and the studies have shown that a neuropathy patient will feel better for a certain length of time. But then once you withdraw that stimulation, then you're going to be back to square one. Hence the reason why you have to address the multifactorial or the many factors associated with the multifactorial condition of fibromyalgia.
And let me take that one more practical step again for the patients who've come in, because for those of you who haven't quit looking, or even for those of you who have quit looking, this is a perfect example. Every one of these studies is starting to spawn a treatment. Okay, but they're not being put together, as Dr. Gates has said, and that we've iterated prior to this. And so, so what happens? We had someone in this area, actually, I think it was up in the Gray Eagle area or something, that was advertising in one of our local healthcare magazines, this magnetic stimulation. I noticed they didn't advertise it for very long. And the reason is because these machines or this medication or this anti-inflammatory or this brain thing that you're going to do 12 times by putting electrodes on you are going to give you some minimum relief. Maybe I'm going to give you a lot of relief, but it's going to be for a very short period of time until you stop doing that. And it's maybe better than a drug if you don't mind going and doing it for the rest of your life, but it can get quite expensive doing that. And the rest of the processes are going to continue to break down while you're doing it. I've had patients come and go, well, I felt better, so now I got to do it every 2 weeks forever, and it's worth the $50 I do to do it. But in the meantime, the rest of their systems are breaking down, and eventually, if you're following what I'm saying, I think you'll agree that that's going to stop working for that patient. And so for those of you who have tried all of these things, this is why you have met frustration, looking for the next silver bullet. And we do have, we're going to sound like used car salespeople. We're not. We're just trying to educate you. We do have a module called "There's No Silver Bullet," and this basically expands on this concept. So that's important, because a lot of people come in, they're frustrated. Their neighbors told them they saw something, but they were hesitant to come to the next great thing because they thought, well, I've already tried all these things and it didn't work, so why is this going to work?
Right.
So this is why this is going to work, because we evaluate all the, look, we can have 100 fibromyalgia patient come in here, and there's maybe 50 moving parts to fibromyalgia. We have to find out which 8 are for that person and which 6 are for that person. Those 4 that we talked about are a core, but they cause a lot of different problems that need to be addressed. To calm those down, you need to figure out which one is right, which one is not right. Well, which one is the ones that are involved with that person. And then there's even a hierarchy as to how you go after these systems. And it's a little involved, but again, this is why this single modem, single approach, this single therapeutic approach is doomed to fail. But you're going to see it spawn more and more, because doctors are not going to take time out of their life. They don't, first of all, they don't even know if you're fibromyalgia, what it is. The rheumatologists don't want to treat you. If they come across one of these videos, they call us. We just had somebody from England last week who wrote us a very nice email, and is just wondering if we teach classes on this, and would we talk to him about it? And yeah, we'll talk to him about it. How much is he going to teach in like a phone call between here and England? Okay, not much.
Oh, that was a very nice email.
It was, no, it was very clear. Well, I don't know if you chatted back with them yet or
I
not.
did, and so
and it's given us some ideas on this.
Contact.
But the reality is that person, probably a minimum amount of 250 to 300 hours would have to be put in by a doctor just to get the very basics of this. And there are doctors that are doing that, okay? But as you can imagine, not a lot. And then there are parameters on the medical community doctors as to what they can do within the framework of this anyway. So they're going to give you the medications. They might give you a diet. They might send you for someone with the magnets. I'm just trying to tell you this because I have seen the frustration in patients who either came here out of desperation or who were dragged here by a well-meaning spouse or whatever, who were just like, they were already done because they'd already been through this. That's why you're going through this. These are not dumb people. These are not bad people. But if they see a single modality that's going down fibromyalgia, and they're going to buy it, and these machines aren't cheap, and they're going to buy it, and they're going to like start bringing people in, and they're going to start putting it on there, and they haven't been told, well, this is only going to help it for a limited amount for a limited period of time. And now they see patients not getting better. The advertisements are going to stop in the newspaper because they're tired of getting kicked in the teeth by patients who are frustrated and have paid, because most of these things are not covered on insurance. So they're tired of, that's where a lot of you are. So we want to really bring this aspect to you in in this presentation. We want to cover everything so that you are totally understand the playing field that you are on. Okay.
And I will say to our group in England, we are excited to talk with you. And,
yeah.
Probably a next phase
Yeah.
in our and everything we have going on is to teach other doctors what we have come across, and we can talk to doctors in terms of the literature and if this may foster improved patient outcomes of fibromyalgia in the UK, then we're happy to do that in any way we can.
Yeah, I didn't mean to diss that.
Yeah,
I wasn't doing that. I was just saying that it's a challenge because we sat and talked about it this Saturday morning. We meet every Saturday morning. We talked about it and I was like, how can we do this? Because frankly, I mean, we have a life. We're kind of busy here. Dr. Gates just restarted his effort to finish a peripheral neuropathy book that we've been saying was going to be finished about 2 years ago, April, because
if somebody hadn't edited it so hardly and I had to make all the corrections, it'd be done by now.
Yeah. Well, I had to do this. I had to edit it so that it was like in English because it's designed for you. Right. It's designed for the lay public. And so it's a collaboration, but the point being that we're doing a lot of things. And so we're kicking it around and trying to figure out how we could do it. We don't want to just like teach it and have a bunch of people come in and go, yeah, and take a test and then go out and not be able to do it. There's too many things out there like that. That's not me. If I'm going to spend my time doing it and that patient or that doctor is going to spend their time doing it, by the time they're done, it's kind of like our patients. If you come in here and we treat you, you better get better. Okay, it's kind of like if they come, we do something and they're going to do it. We got to present it in a way that they know how to do this, so that they don't go and get their teeth kicked in the first 3 months and quit. So that's kind of where we're at on that. Right. For those of you in England, that was what that comment was all about. We were very excited about hearing from you, just for the record. Okay. And these other things?
I think you kind of hit this. I think we've hit all of it.
You kind of hit all these. And I think that's pretty much, you talked about the cortisol and you talked about the exercise a little bit, kind of a bit, and all that type of stuff. So I think that's the best job we've done at covering this so far. And part of the reason is since the last time we did this, we've seen more patients. We fine-tune more things. The research keeps coming out. We'll probably do another one in these 6 months for more of the research. I think, though, what we have presented is going to be the framework in which everybody's working forever, because we have identified the systems that are involved clearly. If we didn't, our patients wouldn't be getting better. And certainly there is going to continue to be more and more and more that's going to confirm it. And there will probably be other research projects that come up with a new piece of data that is going to be new, and it's going to help us to refine what we're doing, which is why Dr. Gates is continually online doing the research. He's a very good researcher. I am not. There's a talent to researching, and I don't have it. And so we'll keep you up on this, but I hope this answers your questions. We can't take personal questions. We've been saying this now for about 6 months. For the same reason that we're thinking about this on, this educational program. I mean, there's just only so much time in the day and in the week and in the month, and in the year, so to speak. Dr. Gates was answering, 2 and 3 hours of these and enjoyed doing it. Okay. But we do have powerhealthtalk.com. And everything we talked about here is on there. There are people who feel that they can look at all those things and try to put it together. If they do, we encourage you to do that. If you have suggestions for topics that you think you would like us to cover, we're all over that. Please send them to us. We want to spend time doing what you want to hear, and we do take patients. We are selective in it only from the perspective that going and handling these moving piees can be a challenge for the patient, and it's kind of a different model in a lot of ways. Some of the therapies are very powerful, but they look almost too simple. Some of the dietary changes are ones that I've had patients say, well, I just, sick patients say, well, I'm just not going to give up my this and that. It's like, okay, then you're not ready. Then we're not going to treat that patient, because that's going to be a failed case. So why even bother? And there's just a lot of things. You have to have support of your spouse or your significant other. There's a lot of reasons why a patient may not be the best candidate for these types of things. And if you're not from this area, we're in lovely Reno, Tahoe, beautiful, beautiful, beautiful area. We're here. And if you're not around here, we will do, you can look online, we will do powerhealthtalk.com. We have our whole procedure online. We will do a consultation at a fee, and the fee is mainly not even for the 45 minutes or that I would do the consult, but we do these consults. You send all of your stuff to us, and we look it over. People are shocked that we know their records inside out, upside down, and back, because the answers are going to be in there. So we do that. We've kind of morphed into doing that. Again, obviously we have kind of like time crunches, so we have to make our time count these days. But other than that, we hope that you enjoyed this, and we hope that it's valuable to those of you who are struggling with this really frustrating condition. And we will continue to attempt to come up with real meaningful topics for you in next week and into the future. So until next week, thank you for watching, and please share this with anybody that you know that has fibromyalgia.
Thanks for watching.
All right.